There are 1,000,000 ways to die. We just wanna talk about it. Codeheads.
Welcome back, Codeheads.
Welcome.
Bonjour. Well, we are here today to talk about women and myocardial infarctions because it is not only Wear Red for Women. It's February, cardiac, not to date us whenever you're listening, but it is Heart Month, and I'm wearing red for those of you listening. And I'm very proud of myself for actually having a red top. But we wanted to talk about women and MIs because it is something that is often missed or misdiagnosed or dismissed. And there's a plethora of reasons for that. So Mike and I really wanted to talk about some of the differences between men and women when it comes to MIs. We could go on about that for days, just in general. That's a different podcast, probably. But we also want to talk about like the symptomology and some of the science behind it, and kind of go from there.
And create some more awareness, in fact, because heart disease is the number one cause of death for women.
For show, and I don't think that most women know that.
Nope. Most men don't know that either. And so we need that awareness for the providers as well as the patients.
Yeah, for sure. I think one of the biggest things is that, and I think that every provider knows this, and I think that lay people kind of know this, but when you hear about heart attacks, when we see it in TV or when you hear about it, you hear about, oh, I had this crushing chest pain. It was like an elephant sitting on my chest. And, chest pain is one of the biggest symptoms. But that is primarily for men.
Yeah.
When they are having an ST elevated MI, a STEMI, which is, for the lay people, one of the bigger MIs that you can have, they have this huge chest pain. Men have this chest pain. It's like, oh, I can't breathe. And it radiates down their left arm. And it's a whole thing, right? And it's very textbook. But for women, they are 1.5 times more likely to not have
Right.
any pain with a STEMI. They
Yep.
are not getting that crushing chest pain. They just don't feel it like that. It might feel like, oh man, I had a big breakfast, or, like maybe some epigastric pain, like, they feel really full or almost nauseous, but not, boy, I'm having a massive heart attack.
And I mean, crushing chest pain is easily identifiable. And like you said, for men, it's like chest pain is the rule. For women, chest pain's optional.
It is
There's
optional.
So we have to figure out what are the factors that are contributing to the MI in terms of symptoms outside of chest pain. So we got to think a little bit outside the box, outside that conventional box that we've established for MI symptoms.
Right. So, for women, it can be that they're having some shortness of breath, or, they may, as I said before, they may feel nauseous or feel like they want to throw up.
Yes.
They may even throw up, just extreme fatigue.
Yes.
I mean, that's my baseline. So who knows if I'm having an MI, but really tired, fatigue, a pain in the jaw or neck, or, upper back in between your shoulder blades.
Yes.
Sometimes it's lightheadedness or dizziness, sweating, just really feeling like you're having indigestion.
Yes.
And those are some of the really, those are overall predominant, signs of MI. But for women, really it tends to be that nausea. It tends to be the fatigue. More symptoms that are a little bit like, could be or couldn't be,
Right. They're vague.
Yeah.
And you have, I mean, the lethargy and fatigue can be going on for a while, not just one day. We're talking weeks leading up to a potential MI. And epigastric pain, nausea, vomiting, you could attribute that to a lot of things. So
For sure.
these symptoms, these feelings are readily dismissed, unfortunately, because they're not quite tangible. Like you can't really apply them to an MI. You could associate them with a lot of environmental factors, or I ate this and that's why I have indigestion.
Oh,
Or
listen,
I haven't
yeah.
slept in a week. That's why I'm tired. I'm stressed. Right. And that could all be possible.
And
That's
I
what,
could say it's January and February in New England. We, have been living through blizzards. It's freezing cold. No one wants to go outside. So, we're having some seasonal affective disorder. So that's why I'm tired. And,
right.
the norovirus is going rampant through the schools, So it's like, it would be so easy to just be like, "Oh, it's probably just a touch of the norovirus, and I'm exhausted because, life is depressing right now." Easily I could brush that off.
Sure. And that's what happens. And that's why they don't seek as much, they don't go to the providers. They don't call EMS. And the providers themselves could say, oh, you're just, it's just winter. So don't worry
Right.
about it.
Yeah.
We're not
Yeah.
going to do a 12 lead or anything like that. You don't
Yeah,
want that.
just
So
go
yeah,
see a therapist or a shrink, get some
yeah,
SSRIs will be good.
deal with that. Deal with that.
But, and it's whatever, not to get on a feminist, soapbox. However, I will say that, the the reason that men have, textbook symptoms or classic symptoms is because that's what the textbooks say. When
Um,
they didn't used to include that women have a different response. So you're really taught
yep.
for MIs that they have these massive, it's chest pain, it's the radiating chest pain, and it doesn't tend to get into all these subtleties with women. Like the heavy sweating. So you think of
Yes.
everything you think of with an MI, and that even happens to me with bias. Like, is that when I think of the
Right.
symptoms, I think of, oh, the chest pain, the radiating left, arm, the sweating, and that's not it. And I'm a woman, and I even dismiss sometimes when I have symptoms, for sure.
When, when I was in, EMT paramedic school, also, even, 20 years ago, they would say, all right, this is how a diabetic might feel when they are having an MI, right? They talk about the varying symptoms, varying signs and symptoms. I don't recall much attention being paid at all to women. I learned that sort of on the job and through my own research, because I would see that I did see a lot of epigastric pain, nausea, vomiting, and it became an MI. And because of that, whenever I heard indigestion, it's like I trigger. So I would have a high index of suspicion, especially if it was a woman, because that's one of probably the three most common symptoms is, epigastric pain, nausea, vomiting, GI, shortness of breath, and that lethargy. And it kind of is interesting that it wasn't incorporated into these textbooks. And this isn't long ago.
Right. Yeah. And women themselves are more likely to kind of dismiss these things as something non-cardiac because, as we said, it could be time of year or whatever, but it's like, oh, I'm really stressed right now. I've like a huge project at work, or like the kids are driving me bananas. If you have children,
Yeah.
especially if you have small children, like I got to do this and a PTO meeting, and so it could be, we're telling ourselves we're blowing off these symptoms because we're too busy to
Right.
listen to bodies and to pay attention to it. So when we get that indigestion, it's like, oh man, I shouldn't have eaten whatever bread yesterday or
Right.
whatever it is. And like, oh, the fatigue, I'll sleep, someday I'll sleep when I'm dead. Which might be
Right.
sooner rather than later. And I have said that many times, but
Uh,
it can even be like muscle pains. Like,
big-
you could be like, oh, well, I slipped on the ice. Oh, I picked up my kid weird yesterday. I slept weird, and these are all things that I've told myself when I get a weird thing with my body. Uh, and really, I shouldn't. These are things that should I be running to the ED every 5 seconds, every time I'm really tired? No, but uh, I do also, I'm a little bit different that I do monitor my heart and I have home monitoring because I'm a nerd. Hence that we have this as Codeheads. So I do regularly check my rhythms and run some bio data on myself when I do have that. But it's very easily dismissible, and I understand why.
Yeah. And what's not dismissible, what you won't mistake is if you're feeling crushing chest pain, the classic elephant. You can't say, oh, that's something I ate last night or I got punched in the chest. No, it's severe and it's also going to cause respiratory difficulty. So it's
Right.
black and white. And a lot of men do ignore it, but
Oh,
they drop. So, it's just it's fascinating to me. But one reason, and I'll touch on it later, that women do have different symptoms is because of the type of MIs that they're sustaining differ
Right.
from men. I mean, not all the time, but they have there's more prevalent types of MIs that women incur versus men, which I'll talk about
That's
later.
yeah, that's important. And also because, we have these atypical symptoms, if we do go to an emergency room, you know, there are times that, if I'm gonna finally be like, "Oh my gosh, I am sick enough that I'm either going to an urgent care that I need to get checked out, or I'm going to an emergency, department," which, by the way, if you think you're having, a heart attack, I would say not to go to an urgent care. I would go right to an emergency department, not to give medical advice to people, but an urgent care, will
They're
send
just going to call the
you.
ambulance. They're going
Yeah,
to call
they're
the ambulance.
so save yourself the time.
Time is
Um
valuable. You got to get to the hospital.
Yeah. Um, but, if we're going to go take that time and finally be like, "Oh my gosh, I'm worried about myself enough that I'm going to the ED to get checked out," you know, it's unfortunate that there are many times that we are dismissed by providers.
Uh-huh.
Again, saying, "No, you're just anxious. You're okay." And which Mike's going to talk about these different types of MIs that we have, the different present, actual EKG changes, because they might present and then it's like, "Oh, it's just acid reflux," and
Yeah.
then you've got these, you're having a panic attack. You're
Hmm.
fine. Just take a breath. You're being hysterical. Let's, take it down a notch. Um,
Yeah.
but I think, there's always, somebody who's outside the norm, but most women who are, working women who are, we're not running to the ED every 5 seconds. So I think that just that data point alone, knowing that like maybe a 40, 45, 50-year-old woman is dropping everything to go to the emergency department because they are concerned enough about their own heart and their own health should
Yeah.
be a data point of like, let's
Yeah.
give this a second look. But there are, we are 53% more likely to be dismissed with
Wow.
our symptomology that are saying that it's non-cardiac related than men. And so we are underdiagnosed by
Yes.
50% more than
Yes.
men
And-
and leading to
sorry.
worse outcomes.
Yes, delayed treatment leads to worse outcomes as well. And one thing also is the diagnostics, the tests that they perform on women, they may appear normal. Okay. And a EKG, for example, that's unremarkable or normal does not mean that they're not having an MI. So it's just, again, less obvious data put in front of you, whether it's diagnostic or physical presentation. And therefore, providers underestimate the true risk of the MI.
Right. And that's an important thing because it's, when you go into an emergency department, yes, they're going to do an EKG and whatever, but it might appear normal. Yeah, a
Mhm.
12 lead is going to, maybe not show anything, massive going on, but that's why we do them over time. So
Yes.
we hold on to patients and we do serial 12 leads, and we check troponin level. Like there's a lot of data points that we check. It's not just a snapshot. And
Right.
sometimes women just get that quick snapshot and they're dismissed and sent on their way. And it's
Yeah.
a false sense of security, being like,
Totally.
"Oh, you're fine." And you're like, "Oh, okay. Phew." So and things might resolve, but then that happens again the next day. And you're like, "Oh, I need an SSRI. I need to go. I need a Xanax. Um, it's my anxiety." It's not. And don't override that. Don't override what's inside of you telling you if something's telling your brain this is off with my body, you need to listen to
Yep.
it.
Yep. And like you said, I love the serial EKGs, 12 leads. I would do that all the time because I've seen within 10, 15 minutes, a nice EKG turn into a whopping STEMI or NSTEMI. And that's just 10, 15 minutes, literally.
Mhm.
So it's wrong. Like it's wrong to just take, all right, check, we got the EKG, check, we did this, check, we did that. Everything looks good. You're great. Have a nice Christmas. We need to spend a little more time with them, especially if they're earnest about how miserable they're feeling. And
Right.
if someone says tired, indigestion, lightheadedness, dizziness, we have to pay attention to that. That doesn't mean you're hysterical.
Right.
You feel like
Especially
crap.
yeah.
All right. And
es-
you're worried about it because you don't normally maybe feel like crap like this. It's a little more than usual. So that should trigger the practitioner a little bit when they hear that. And and it's not to say practitioners do not, But the awareness isn't widespread enough to it's warranted, and it's just not in place on the scale it should be.
Right, especially because women are high performers, right? Like, especially if you are, well, no matter what, but especially if you have, young children, like, your body is constantly performing, your brain is constantly on, and you're going, you're you're doing laundry, lunches, cleaning, planning for next week, all the doctors, all the things and stuff that women do.
I know someone like that. uh,
Businesses,
yeah,
you name it.
seriously.
And not sleeping and then getting a puppy. But you do all those things
Uh,
but we are high performers. So if there is something, so sometimes we might pressure providers too and be like, okay, yeah, all right, is it fine? I gotta go. I gotta go. I got a meeting or I gotta go get the kids or yeah. So we're fine. We're fine. You
yeah.
took the time to go to the ED, you know, stay there. And for the providers, like, don't let them pressure you. Like,
Hmm.
what the right thing to do is, and, I know sometimes there are people that we just have to sign out AMA and let them
Yeah.
go against medical advice, but, we really should make sure that we really inform people and let them know why they're staying and what we are concerned about. Okay, so I think this is a good point to actually start talking about the diagnostics, Mike, and
Okay.
what, as practitioners, we should be doing and looking at for
Well,
these women.
we've talked about the 12 lead. Obviously, that's going to occur should right away if someone is coming in with this presentation. I very much like 12 leads. I like assessing them, and we're going to actually have an episode about them, in the near future. But for women, just like with all the symptoms, the EKG changes can be subtler. So you're not going to recognize right away that STEMI, that whopping ST elevation, which anybody could recognize. If I taught my 16-year-old what standard EKG looks like versus a STEMI, he could recognize that pattern, right? But with the women, it's going to be a little more nuanced. They're most likely not going to have that STEMI. They're going to have an N STEMI, it's called. So there's no ST elevation. They're going to have some baseline abnormalities, say in the QT, T wave changes, ST depression. And a normal EKG, like I said earlier, does not rule out a STEMI. So when you don't see that ST elevation, you can't just wipe your hands of it and assume your EKG is unremarkable, because it's not. If we do have T wave changes, if there is QT extension, if it is an N STEMI, if there is ST depression, those are markers. So we need to pay attention to them. So they might be more subtle versus that big STEMI, the ST elevation, but they need to be incorporated into, an index of suspicion. Basically, we just have to consider that the subtle changes are big changes potentially. I'd like to talk about troponins. All right, that's a cardiac enzyme. That's a test we take. Baseline troponins between men and women, the levels, women are lower. Their baseline levels are lower. Peak troponin rise is often lower as well. Time to elevation may be delayed. So really, using male troponin thresholds in women is a way to miss an MI.
Yep.
So we need to have sort of a different approach for each sex. Otherwise, if we're just sort of like, if we're going off male presentation, oh, you're not having crushing chest pain, you're not having, numbness or tingling in the extremities, you don't have jaw pain or any of that, you're not having an MI. This is similar in terms of the diagnostic, where we need to have targeted specific troponin thresholds for women and then apply that when we get our test results.
And that's interesting because you don't see that at a lot of places. I know that,
Oh,
for example, when on the not being the, being the provider, when we, send off labs and then we're looking at the results, they're not usually, for troponins, it's not like, "Oh, this is a woman." Like, there are some labs that take into account, gender or, age or, kidney function, all these different things. And so it, kind of is like, "Oh, take a beat when you're looking at this result," especially if it's abnormal, or sometimes when it's normal. But troponins, as you're saying that, because I knew what you were saying, but at the same time, I was just thinking, I don't think in all the various places I've worked at, I don't think I've ever received that warning, like,
totally.
based on gender.
Yeah.
Uh,
I mean, I was surprised when I originally heard about it. And now I'm not so surprised, because it seems, again, we need to target women and not just target what an MI looks like or what it's supposed to read with diagnostics.
right.
Um, Two other things with diagnostics. So, two most common types of MIs in women. So one, I call it Minoka. myocardial infarction with non-obstructive coronary arteries. So here again, the arteries, so it's non-obstructive. The arteries may look normal on an angiogram. So once again, all is well. You have no blockages. Don't worry about it. All right. These MIs are caused by like coronary artery spasm or microvascular dysfunction. Again, often missed, often minimized. All right. So that's one. Other one, I call it SCAD, spontaneous coronary artery disease. So it's like a tear in the artery wall. It's more common in younger women, pregnancy or postpartum as well. Women without traditional risk factors can incur that, and it could be life-threatening like any other MI if it's misdiagnosed initially. So we sort of have a theme going here, don't we?
We do. We're magical.
And so take it from there because I have something else, but it's not quite related. So you go
Okay.
ahead.
So, and speaking of how magical we are as women, is that
You are.
what thank you. Is that, we are special in many ways, and one of the big things that makes us special and why we kind of tend to dismiss our symptoms, which we've talked about some of the reasons before. We're busy, we're always doing things. But one other thing that we need to start thinking about, which can happen, at any age, and it can start as early as your mid 30s or, a little bit later, but is perimenopause. And it's something that people have been talking about, and there's more awareness to it now than there had been previously. But some of the symptoms match that of an MI, of some sort of a cardiac event happening, such as that unusual or extreme fatigue. So, because of the fluctuating hormones, we can have, weeks of absolute fatigue and brain fog, and hot
Right.
flashes, night sweats, sudden sweating. I think the hot flashes and night sweats people get, but it's not, it's not what hear about, it's not all of a sudden you're just like drenched in sweat. They start kind of subtly before you start getting them heavy.
Right.
We might have shortness of breath or feeling winded when we're, running or doing anything. Um, and maybe have some palpitations. And so people are, oh, it's just anxiety. Oh, I'm just, just a little thing that's new. But that again could be related to our hormone fluctuation, or it could be an MI. The nausea,
Yeah.
indigestion, stomach upset, classic.
Wow.
Having that heartburn sensation, classic with perimenopause, also with a heart attack. And as I said, the an increase of overall anxiety is huge, and it's related to our change in our estrogen fluctuations. Um, and then the aches and pains. So pain in between your shoulder blades, in your
That,
neck, in your back, in your, you can have it on your jawline. And, women are like, oh, I slept funny, or it's this, that, the other thing. And, it could be perimenopause. It could be an MI. These are important things to check out. I remember I had back pain, like searing back pain. It felt like someone was sticking a knife in between my shoulder blades for like 2 weeks. And I kept being like, oh, I just pulled something. And then finally I was like, "Oh my god, I wonder if I'm having a cardiac event." And then it turned out it was my first sign of perimenopause, was
huh.
that it was like someone was jabbing me with a huge knife in my back. Um, so, it's important to think about it and not just blow it off, and not just say, "Oh, I just, I slept funny. I need a new pillow. I
Right.
need." We do need to dig into it. We do need to talk to our providers, and you know and see what's going on. And at a minimum, go
Right.
seen.
But what you did is you addressed a concern, and it wasn't an MI, but that concern, at least an MI, was ruled out, and you were
For
able
sure.
to maybe figure out what was going on. So that's, I think, what we're talking about is if you have a concern, it's legitimate. And if it's lasting and you're brushing it off, that tells you right there. We know when we lie to ourselves a little bit. That's when we should go in, right?
Yeah, no, I finally was like, this
You
is
don't want to wait weeks.
mhm,
Mm.
don't be me.
So one thing I thought of this 2 days ago. So when we talk about disparity in care, for example, the lay rescuer is less likely to expose the woman and put the pads on,
Mhm.
um, you know, because of modesty and they don't want to get in trouble or cultural reasons. Now, as in the pre-hospital arena, because if a man has chest pain, boom, he's getting the 12 lead shirts off. no question. If he has shortness of breath, if he had a syncopal, if he looks like a heart attack, we're going to put them on. Now, the truth is, we don't do as many 12 leads on women. Now, one, because of the reasons we discussed today, which is, oh, you have, and it's fair, you have nausea and vomiting. Okay. Won't necessarily do a 12 lead. Oh, you have lethargy. But when these things start to add up, we also need to be aware, because they need the 12 lead. But, truly, there's a reluctance to do 12 leads on women. Why? For those that don't know, these leads, there's 6 of them. It could be on the right side as well, but primarily on the left. You are surrounding breast tissue. Your hand has to go there. And
You have to lift breast. I mean, if you
yeah,
are
and I will always say, I'm using,
going
because
down,
after a while, you get used to touching people, and you do it the right way and have the proper demeanor. It's fine. I'm like, I'm going to use the back of a gloved hand. I'm going to lift here. You tell them exactly what you're doing. I mean, a big part of the job is learning to touch people. I know that sounds strange, but it's true. And it's like, we need to get our hands on them. We need to get these interventions on them. But I'm sure I did it early on, and I know others do too. You're just a little more hesitant to put that 12 lead on. I mean, if they say I have crushing chest pain, yeah, I mean, you better. But with these vague symptoms, I think if you hear those 3, like we've talked about, the lethargy, the GI, shortness of breath, definitely. Anything like that, anything we've discussed, say, why not throw the 12 on? You're not going to get in trouble.
I'd like to say, on behalf of all women, if we are having if we're having an MI, please touch us and do the 12 lead. If we are, need CPR, please expose me.
Yep.
I'd rather get compressions than die with my clothes on.
And you
Um,
have to get over it. You have to get over it.
yeah,
And, that's the thing. You just do it. And the more you do it, the more you do a 12 lead, you're going to be more comfortable. All right. And you don't want to miss something just because, oh, I just don't want to do that. Like, I
right.
get it, but we got to do it.
Yeah.
Touch people. Just touch people.
Just touch people. If you take nothing else away from the Codeheads, just touch people.
Yes.
And on that note, you can always email us and just reach out and touch us.
Reach out.
Well, thank you guys for being a part of our Codeheads. Don't
Good
forget to
show.
help
Good show
people.
today. I enjoyed that.
There are 1,000,000 ways to die. We just wanna talk